Wow, those are two very tough acts to follow, but thank you so much for the invitation. It's really an honor to be here with this esteemed panel. And I am going to talk about how everything you just heard with the STRIDES framework really does manifest into everyday care, particularly across a variety of hospitals that I have the privilege of taking care of in the United States. And I really want to, I hope, bring home the points that both Luke and Maria Virginia made in the value of, from an antimicrobial stewardship and a diagnostic perspective, of how it's way beyond the cost of the individual test and how it truly impacts the care of not just the patient in front of you, but the entire population, the whole ecosystem of care, and can have benefits beyond really what we even dream. And I'll share a couple patient examples to show that. So I'm really proud to say that within my health system, so I work at the University of Pittsburgh Medical Center, we have 37 United States-based hospitals across 3 different states. And so we have all the fun of kind of navigating different regulations, different rules, different government structures at a state level and then our national level. So there's that piece of the puzzle to all of it, as I'm sure we all face across different regions, states, territories, et cetera. But we, over the last several years, have made a concerted effort to think about diagnostics in terms of their value, as Luke emphasized, for the individual patient, for the population as a whole, and for our ecosystem as a care provider. And so, like I said, we have 37 hospitals. Our hospitals range from a 9-bed critical access hospital in our most rural area to about a 700-bed academic teaching medical center in downtown Pittsburgh. I have several large teaching community hospitals ranging from about 300 to 400 beds. And then I have dozens of 50 to 200 bed community hospitals in relatively rural areas of the United States. Before September of 2025, this system operated on 11 different electronic health records and some on paper. And so in terms of getting data, trying to navigate diagnostics in different labs, accessing things and tying care together in a way that benefited everyone, we had to build things. For COVID-19, I had to build order sets 11 different ways and also on paper. We also had 13 different ways of doing antimicrobial susceptibility testing across my infrastructure, depending on the different commercial platform that they had, whether or not they had an identification system for organisms. Many of my institutions still lack rapid identification system for most culture. And so when we think about standardizing and value and care, that's just to kind of level set what we were operating in. We did convert about half of our hospitals to a single electronic health record in September of 2025, and the other half will be going to that singular record in October of 2026. So the future is bright, but I'll talk about the infrastructure we worked in. And so if you're thinking, wow, that seems really daunting, or what the heck, you're not wrong, but it is really fun for me, and I really love my job and feel really privileged to do this work. It really drives me to invest in this infrastructure to make doing the right thing easy and to make taking care of patients for bedside providers easier. Because we can talk a lot about the value of these things and how we bring this care together and what we should be doing. But for any of us that work in any aspect of healthcare, you know that doing this is actually really hard, and whether it's because it's justifying the cost or simply making it operationally feasible for people to do the right thing, that's where this work really lies. So my background and my work is grounded in antimicrobial stewardship. I am an infectious diseases trained pharmacist, and I spent the first 4 or 5 years of my career exclusively doing antimicrobial stewardship, in so much as I was performing prospective audit with feedback, calling providers, and trying to talk about the right antibiotics. And I realized I was thinking about this the wrong way, because I can look at, 30 to 40 patients a day, maybe with a 7-8 hour day of true patient care plus everything else we have to do. And I can call on every individual patient, and I can recommend stopping ciprofloxacin for asymptomatic bacteria or de-escalating cefepime to ceftriaxone. But it was the infrastructure that was broken and the lack of ready, fast testing that would really move the needle on patient care. So I became a huge quality and operations nerd as I moved into this stage of my career. And I'm a really big believer in this Donna Beaton model. If you have not seen this before, this is really grounded in what we call structure, process, outcomes, and I think really resonates and synergizes well with the STRIDES framework. So structure includes all of the factors that affect the context in which we deliver care. So this is everything that we may not think about, but it really goes to function on how we improve this. So it's the physical facility you're sitting in, it's the chair you sit in all day long, it's your computer, it's the humans, it's whether you get trained or not, it's how you get paid. And structure is almost always the upstream cause of any of your problems, whether you are working in a lab trying to do groundbreaking research, whether you are out in communities trying to administer vaccines, whether you are in a hospital, in a clinic, it is always a structure problem. Process is then the sum of the actions that make up healthcare. So process is how we diagnose, treat patients. And then outcomes is really the holy grail, right? Outcomes is what we want to see. And importantly, in this quality model, it doesn't really tell us what a good or a bad outcome is. We get to define that, but it says how we can think about getting to a common goal and really thinking about this structure. So this really drove me, and I was in a position where I unofficially led system level work for about 2 to 3 years during the pandemic. And I think we all kind of felt that, right? COVID was none of our jobs until it was all of our only job for about 2 to 3 years. And for better or for worse, the pandemic was horrible, but I think globally, it actually moved us to work together for one of the first times. And across at least American healthcare infrastructure, you know, small hospitals have been being bought by larger systems, and we talk about being systems, but we're really not. But in the pandemic, we actually functioned as a system, and we thought about care at a population level. Everyone had access to clinical trial enrollment. It wasn't just limited to academic sites. We were enrolling people in the communities. In fact, community hospitals were our highest enrolling environments. And so kind of coming out of the pandemic, you know, 2022, 2023, I don't know if you guys felt this way, but I woke up one day and I was like, am I just supposed to go back to like looking at patients with asymptomatic bacteria? Do I even remember how to treat cellulitis? The answer was no. It was kind of this existential crisis of like, how do we just go back? And do we want to? Do we want to go back to the way things were, or do we want to take the lessons we learned in the pandemic and use that structure and actual systemness to think about value in a different way? And so I actually made up my job. I wrote the job description I currently have in June of 2022. I'm just very thankful that my health system leadership believed in it. I direct infectious diseases strategy for our system, and we created in that the Infectious Diseases Strategy Collaborative, where we brought together a very small group of system leaders. We had representation from all of our geographical regions, and we brought these service lines together: infection prevention and quality control, antimicrobial stewardship, which in the United States is predominantly pharmacist-driven, clinical ID, which is physicians, nurse practitioners, people diagnosing and treating patients, and then importantly, the microbiology labs, which has really expanded to all lab work. So special chemistries, clinical lab work, it's really gone beyond, because we realized, and really to Luke and Maria Virginia's point, if I as a pharmacist go and say, I need this antibiotic that costs $1,000 a day, I promise it's good for patients, I live in a very unique silo, and what I can impact is very narrow. We cannot prove the value of these things across the care continuum unless we work together and we share budgets and outcomes. And so the poor labs, you poor lab people, you guys always take the hit. That's so not fair. You bring on new diagnostics and you have to spend the money on the individual kit, or I like how you call it a kit. That was actually like really fun. A kit or a test or whatnot. And we're like, we want, at my system level, if I bring on a rapid diagnostic test, I'm talking the magnitude of $3 to $6 million a year because of how many tests we run. And I'm asking the lab to pay for it and not reap any of the benefit. Like, how do they get back to their line that it actually improved the care of patients? And so this is what this team strives to do. We officially had our first meeting in the summer of 2023, and now 3 years into this work, I think we're really in a cool groove, and I'm super proud of what we've been able to accomplish. So I'm going to share 2 examples today. So the first one was the advent of widespread rapid carbapenemase testing. And so Maria Virginia highlighted this a little and the importance of this. So this was a patient at one of my hospitals before this group was able to roll out this diagnostic initiative. So this was a patient at a 400-bed hospital in Altoona, Pennsylvania. No rapid diagnostics at the time, no MALDI, takes days and days and days to get culture and susceptibility. And they had this patient pop up. And when you are faced with this on day 4 or day 5, when you finally get this information, you look at this and your first thought is that just wrong? Because that's a really weird phenotype. But even if it's wrong, it's going to take you a day or 2 to rerun your automated susceptibility testing to confirm it. Or you're like, is something going on here? Now, Klebsiella is a weird bug. It makes a K1 enzyme that functions as an ESBL. It can be hyperproductive, but this is still weird. Seeing ceftazidime, avibactam, high-level resistance, meropenem, vaborbactam's reading susceptible, but please note the meropenem and merovabor MIC are actually the exact same. That interpretation is a breakpoint difference, which is a whole nother set of rules in the diagnostic space. But when you have this patient in a hospital that has no rapid diagnostic testing, you have to consider that this might be a carbapenemase. And then what would I do in that setting? I have to take care of the population. And so sure enough, the infection prevention team at this hospital emailed me and a couple of my colleagues and said, do I have to consider this patient NDM exposed? And they sent the isolate to Pittsburgh, but now you have to wait for the isolate to be subbed, shipped, tested. And in the meantime, you have patients to take care of. And oh, lo and behold, this patient also had a roommate, because in some of our wards and some of our communities, we still don't have single bed resources for every patient. And so we're like, well, I think we should consider this a carbapenemase producer until proven otherwise, activate your infection prevention plan. And they're like, well, what do we do with the roommate? Okay, so now we've taken days, 3 extra days, where the patient was exposed to a whole cocktail of unnecessary antibiotics because we're covering an NDM until we know better. Luckily, this patient had a fluoroquinolone susceptible isolate, but if it hadn't been, this patient would have been on polymyxin and other crazy stuff in the absence of knowledge. We had to impact not only this patient's family by isolating the patient, and even just the words we use for infection prevention, right? How terrible to be isolated. We had to do that to a non-infected family and a non-infected patient. They had to be moved, and all of the resources that go in with that, which is really crazy when you think about it. And so that, I think this is what we're really getting at when we talk about value and not just cost. And so this patient case and several others gave me the impetus to do one of our collaborative initiatives, which was widespread automatic carbapenemase testing. And so this was one of my dreams. I wanted this bad. This was a hill I was going to die on. And so I came prepared, and I wanted to implement automatic carbapenemase testing for every Enterobacterialis from any clinical culture that was meropenem resistant. And I came so prepared. I had my business case, I had my ROI, I had these patient anecdotes. I spent a lot of time on this, and I even pre-compromised in my head because I'm just so used to having to justify these things. And I said, okay, let's start with meropenem resistant only, although we all know that you very well can have ertapenem resistant, meropenem susceptible carbapenemase producing isolates. And we would miss that small percentage, but I was willing to compromise to try to get this done. And actually, because we have this structure where the lab is at the table and getting credit for this work, the lab was like, I'll play. And they actually, this is one of those surprising things. They were like, this is actually a very technically easy test to run. It's actually not that super expensive dime for dime for the actual test. We're happy to implement it. And they were like, and by the way, Erin, again, operations and structure are so key. They were like, it's easier for us to do every carbapenem resistant organism no matter what. If we have to separate out ERTA versus Miro, that adds a layer for our technicians that we don't want to add. Can we just do every isolate? I'm like, what? Yes, please do every single isolate. And so we implemented carbapenemase testing across all my labs. This was a strategic system initiative. Any positive result gets emailed to a core team that consists of 3 pharmacists, one of whom runs a research lab. So it's this really cool process now where I can immediately act clinically to recommend appropriate antibiotic therapy. Infection prevention is looped immediately. A couple of physicians are looped immediately. And then my pharmacist colleague who runs an amazing research lab gets the isolate shipped. And so he got to go from working kind of at one hospital and, you know, collecting patient isolates to now a whole system infrastructure of epidemiological tracing, whole genome sequencing on these isolates, and other research across our system infrastructure. And it's very simple. If the test is positive, they send an email. We created a service account, so instead of having to email individuals, they email one thing. Again, structure, make doing the right thing easy. And they just say, hey, this was positive, here's where the patient is, here's the isolate, and then the lab's done. And then we take it over, but all of that happens very quickly. And so is carbapenemase testing worth it in the context of the STRIDES framework? And I'd say absolutely. And we can talk through spectrum value. It lets me prioritize narrow spectrum agents when it's carbapenemase negative. And importantly, because this is also good antimicrobial stewardship, it helps me escalate therapy when patients have carbapenemases or are at significant risk, because escalation is just as important if that's going to save a life. Transmission value speaks for itself because of how quickly infection prevention is involved. Research, I kind of talked about what my colleague is being able to do in this space, as well as everything else in terms of enabling, you know, accurate patient cohort enrollment and thinking about how patients are bucketed with these kinds of tests. From an insurance perspective, we are preserving antibiotics. And from a diversity perspective, I'm the pharmacist, the stewardship pharmacist on the stage saying it. This patient needed a fluoroquinolone. Like, how often do we say that? Never in today's day and age. But, you know, there are really good antibiotic classes that we try to save or we try to avoid because they may cause more harm or be associated with more toxicities. But at the end of the day, this was actually a really good use of a fluoroquinolone. And that helps me save some broader spectrum beta-lactam, beta-lactamase inhibitors for when I have no other option in that space. Enablement could go on and on and on, but I'm actually just going to go to the next slide because I think not only is there the STRIDES framework to consider there, but there is everything even beyond, because the framework is beautiful and it really tries to capture everything we just talked about. But some of these things are intangible and almost impossible to put a dollar amount or a value amount to, but man, are they impactful. And I already kind of shared it, but the impact to the roommate, the impact to the patient, not just from their physical health, but their mental health. Being isolated is terrible. The shipping costs, the lab time to have to sub that specimen, all of that waste and resource. And even, I mean, we've talked about it at this conference particularly, we think of IV to PO. That patient was on like 3 IV antibiotics while we waited, whatever. Nursing time to administer these antibiotics, it goes on and on and on. I'm gonna end and move in with a very personal story about the benefit of diagnostics as it relates to blood culture rapid diagnostics. This was my paternal grandfather. He passed away a couple years ago, but he was my very best friend and really, truly the best kind of human. He's from a very small town in West Virginia, very, very rural, about 800 people. He grew up on the Ohio Riverbed in Old Pittsburgh with the realm of the steel mills. And I could go on and on and on, but I will kind of try to summarize who my grandfather was for you to try to put this into context by telling you the following story. Toward the end of his life, when he wasn't able to drive anymore, he was from, this town had 1 traffic light. Everyone lives within 45 seconds of each other. I mean, really rural America. But he used to go downtown. There's like 4 stores there. But he would go downtown to have coffee with the other 4 men that lived in town in their 90s every morning. But kind of at the end of his life, he wasn't able to drive anymore. And this really upset him. And I was like, Grandpa, someone will come and get you to take you to coffee every morning and then bring you home. You can still go have your coffee. And he was like, you know, see, Erin, I'd really just rather give than receive. And like wouldn't ask for a ride to get his coffee. So this is my grandfather. But okay, but back to diagnostics. So I live in Pittsburgh in the upper right corner there. And you can see from the white, that's a city. So really industrial, urban, lots of people. In that upper right box, there are 8 UPMC hospitals in like a 2-mile radius. Healthcare, thriving, lots of access, lots of people. As you go to the left, it's very green. This is very rural, as many of our communities are. There is very limited access to healthcare. There are very little people. In fact, the only hospital is this tiny pink arrow Wheeling Hospital. It's a 40-bed community hospital in the middle of nowhere, West Virginia. And right before Labor Day weekend of 2019, my grandfather was rushed to that very hospital because his neighbor found him, quote, shaking on the couch. And we later discovered that he had a cut on his leg that was infected. They swabbed it. They started him on ceftriaxone on admission. My dad ended up going to be with him. I was at work, but I'm texting my dad. So these are actual screenshots from text messages with my father. And my dad's like, he's on these antibiotics, vancomycin and cefepime. And I am like rolling my eyes. I am like shaming this small community hospital. I'm like, my grandfather hasn't left this rural town ever. He has no risk factors for anything. He had AFib, was otherwise pretty healthy. I thought he had cellulitis, and I'm like, Vanco and cefepime, you know, these broad spectrum cocktails. But I think the other important thing here is the top of the text where the doctor said to my family, my dad said, the doctor says it takes 3 days for blood cultures to come back so that they know what antibiotics will work best. He'll be on IV antibiotics until then. Can you imagine telling the family of a patient in front of you, I have no idea what to do for 3 days. They're just gonna sit here on these antibiotics. But this is healthcare. And my dad was like, okay, cool, that's the plan. And we didn't have rapid diagnostics in bloods at UPMC at this time either. And that's the way it was. So then we're texting, I'm like, Dad, what's going on? What is this? I said renal function. I'm like, my dad's not gonna know what that is. And I'm pretty confused. And if you've ever been, you know, trying to communicate with your family through healthcare, you know, even when we think we're being clear, they have no idea what's actually happening. But something wasn't adding up. And I was like, Dad, I'm so confused. Why is he on these broad spectrum antibiotics? I'm like, wait, are his blood cultures positive? And my dad goes, GNR in both bottles. What? I thought he had a cellulitis, right? Something's not adding up here, and it's really hard to communicate. The other factor that I'm sure we all navigate is specialty care is not available in these parts of the country. The ID physician seeing my grandfather was a locums or a traveling physician who was covering 3 different hospitals within a 70-mile radius. He had stopped by my grandfather's room that morning, but then had to make his rounds to cover the entire region, wasn't going to be able to go back, and probably didn't even know that my grandfather had gram-negative rods in his blood. The next day, so we're at like 48 hours after he got admitted with shaking, the organism ID came back as Acinetobacter baumannii. And if you're thinking, wasn't expecting that, you are correct. This was quite a surprise for a man who has no travel history, no risk factors, and really we didn't know the source at the point. But when I hear this bug name, I remember how I physically reacted, and like I promptly forgot everything I've ever learned about treating infections. And I do gram-negative resistance and transplant ID. And I remember just the physical reaction of being like, I have no idea what to do. Like, am I really about to give my grandfather polymyxin? This was 2019. There was no Sulbactam, Durlobactam. There was no Cefiderocol. And I remember my mom and dad at the time, my family had come together at that point, and my mom looked at me and I heard her say to my dad, I think we need to be more worried. And I left the room and I called 4 of the world's leading experts in the Acinetobacter space. I'm very fortunate at the University of Pittsburgh to work with and know people in this sphere. And if you are thinking, well, you must have got 4 of the same answers, the answer is, no, I didn't. I got 4 completely different answers because, again, treatment paradigms, diagnostic testing, do I know if it has an OXA or not? We knew none of that. And in the absence of that, we have to do the best we can with what we have. And 4 of the leading people in the world in Acinetobacter baumannii and gram-negative resistance gave me 4 different answers. And I was like, all right, guys, I'm not going to do what any of you said. And I decided to do what I wanted to do. And I couldn't bring myself to give my grandfather polymyxin or colistin. So we started him on high-dose meropenem, high-dose minocycline, and Unison or ampicillin sulbactam. And by we, I mean I was covering this cross-covering specialist physician, trying to explain to them, I'm calling this small pharmacy that, by the way, closed at 5 p.m. They've never compounded high-dose meropenem ever. They didn't even carry minocycline because they didn't have accessibility to the antibiotics or the drugs because they're in this rural community. And that's how healthcare goes in the absence of all of this. And I remember at this time, my mom looked at me and she goes, wait, why are we changing his medicine? And I said, well, because the ones he's on don't work. And my mom said, but you told me that you started really broad. And I was like, well, they did. And it wasn't enough. And it wasn't good enough. And then, of course, you know, Acinetobacter baumannii susceptibility testing is not a thing at this hospital. They've maybe have 1 of these pathogens a year. They don't have anything validated in their lab. I ended up going to the lab, taking the plates myself, which is not legal or recommended. And I drove them to Pittsburgh and did them in our lab and I had my friend and colleague do them so that we could get answers faster. I want to be really clear here that this is where patients who should live die because they don't have answers to the questions they need when those answers are available. They just don't have access to the right tools. And we do not have ways to structurally support them getting these answers. So this is really where the make or break is in diagnostics and in access to antibiotics and testing. Very fortunately, my grandfather got better, but I honestly do believe he would have died if I was not an infectious diseases pharmacist. I do not believe that hospital would have been able to provide him the care he needed. He was transferred to a skilled facility to complete 14 days of antibiotics. If you're wondering the source, we never found it. His leg wound grew a Klebsiella. I have no idea where his Acinetobacter bacteremia came from to this day. But here's the other fun part of healthcare, and somewhat beyond diagnostics, but again, thinking about value. We had, at the time, we gave him 14 days of therapy. You could argue now I could have given him 7, okay? But he transferred to this facility, and on day 12, they called us and they said, to complete the last 2 days of his therapy, he's going to have to transfer to a lower level of care because he's doing so much better and his insurance will no longer cover him to stay here. So they were going to move him to another facility for 2 more days of antibiotics. Talk about waste. And so I just stopped him on day 12, which at the time was like crazy. People were like, you only gave him 12 days of therapy? I was like, I'm not going to transfer him to another facility. That is healthcare waste. That is not high value. So all that to say, the work I do now largely focuses on building these care pathways so that all patients in my system have access to the same resources. Your zip code or your, community or your region should not determine whether you live or die. So after we went live on blood culture diagnostics through the whole system, I'm really proud to say in the last year I've implemented 9 machines, consolidated 8 labs so that all of my hospitals now have access to blood culture rapid diagnostics. It was a multi-million-dollar investment that has more than shown the value to the population across our system. This is an example from an 166-bed rural hospital. Within days of going live, they found an OXA48 in the blood, targeted therapy within 3 to 4 hours. We all know this story. We know, I don't have to explain to you how beneficial these therapies are. These are just more examples of emails. Again, hospitals as they went live in the last 2 years saying, wow, look what a difference we're making in patient care. And if the feels aren't good enough, the numbers and the money are there. So we looked at length of stay, which in American healthcare right now is the only thing people care about. We have to get people out of the hospital faster. We need bed space, we need bed capacity. So looking at some of my hospitals, this is actually a pretty complex hospital that does a lot of cancer care. So these patients are gonna have long length of stays for various reasons. But after we implemented blood culture technology, rapid diagnostic technology, the length of stay year over year in the same month dropped almost 3 days. And there are a lot of other efforts going on to try to improve length of stay. And so people are like, well, maybe it wasn't the technology, maybe it's everything else. But no, we've been trying to improve length of stay for years, and there was no change from 2023 to 2024, and then a precipitous change after the advent of rapid diagnostic technology. And so I did look at other things, and you can kind of, this graph is a little hard to tell, but in hospitals that had adopted blood culture rapid diagnostics, their total length of stay dropped almost 7 days. If you look just the length of stay just from the time of the blood culture, it also decreased by about 3 to 4 days. And then in hospitals that had not adopted, there was no change. So our rapid diagnostics and blood culture identification worth it in the context of the STRIDES framework? I would say absolutely. In the interest of time, I won't repeat this. I'll leave this slide up here. And with that, thank you so much. And I believe my colleagues are going to join us for questions.
Wow.